When, please.
Okay. Good evening, good afternoon, good morning, everybody. Thank you all so much for being here with us. Today we have a special guest, Dr. Eduardo Ribas. He's a very prominent neurosurgeon here in São Paulo, Brazil, specialist in tumor surgery. He was Dr. Rhoton's fellow in Gainesville, Florida. And today his talk is about the lateral surface of the brain. So, and also he's my partner. He's in charge of the micro neurosurgical techniques discipline, in São Paulo at the University of São Paulo, and together with me. So this is my partner. So, okay, thank you so much, Eduardo. You can start your talk at your convenience.
Thank you, Dr. Wen. Thank you, Dr. Carolina. It's an amazing opportunity. I'm very happy to be here with friends and with people who have inspired me through all this journey into neuroanatomy and continue to inspire me, of course, into this very challenging subject that we deal with, but it's very, very interesting. And we have a very good group of people, and we share common interests and everything. In particular with Dr. Wen, it's really good to work with you. We are trying to set up our lab at the University of São Paulo. We want this to make it ready to receive international friends from all over the world in the next years. Let's see if we have the chance to have this right, so we can invite everybody. So I was a Dr. Rhoton's fellow in 2012 and 2013, and my main subject of research was actually the central core. But by doing this research, of course, we go through all the brain anatomy, and today or tonight, we are going to talk about the Sulci Gyri of the lateral surface of the brain. So the knowledge about the brain, particularly for its surface, has not been a subject of research from old humanity. In the beginning, the brain was not seen as an essential organ. As you can see here, perhaps the Egyptians were the first civilization to deal with the brain most commonly, but they will see the heart as the main organ of the body, and will just remove the brain to have the mummies made. So here they are getting the brain out of the skull, and here there is a CT scan of a mummy where they have forgotten one of these pieces inside that they used to scratch the brain out of the intracranial space. And so, as I said, the heart itself was seen as the most important organ of the body. It was thought that the heart was the origin of our thoughts, of our personality, of our mental, of our cognitive functions. And through all these years, the brain was just regarded as an aleatory or intestine conformation arrangement. That was not seen as a common arrangement between all people. The first anatomists have already described some of the parts of the nervous system, but has not been given much attention for the details. The heart began to have its second place and be and having the brain as the first place of the organ, to see the brain as the origin of our thoughts by a bunch of people. But Dr. Galen was a very prominent person at that time, and he was studying this wonderful net of vessels that some mammals have on their base. They do collect themselves and form the choroid plexus, and he was very amazed about the CSF. He thought the CSF was the origin of our knowledge, and the anatomists that follow Galen really describe the ventricular cavities and their connections, but did not pay attention to the surface of the brain. Even Leonardo da Vinci, working in the Renaissance, in the 15th century and 16th century, did not pay attention to the surface of the brain, although he paid a lot of attention to the ventricular cavities. Andreas Vesalius is seen as the great anatomist, perhaps the first great anatomist who put this wonderful work together called the Humani Corporis Fabrica. He showed the brain, but did not understand that the brain has a very particular shape that is really consistent among all people. So he did not contribute to any understanding of the brain surface. An interesting person at that time was at the 17th century, who was working with comparative anatomy, and Thomas Willis had described that as more intelligent a mammal was, the more complex the surface of his brain it was. He would have more sulci and more gyri. So now he regards the surface of the brain as the origin of the intelligence. And now the anatomists that will follow him will pay a lot of attention describing and naming all the surface of the brain. The brain has its shape because all the central nervous system is formed by a canal and the neurotube, and then the neurotube first dilates itself into vesicles, and then has a lot of process of folding and infolding. What happens that the surface of the brain begins to get inside the brain, just like a carpet that's been folded and infolded together. What we say is that 2/3 of the surface of the brain is not actually on the surface of the brain, it is hidden inside the sulci and the fissures of the brain. Here's a nice theory that is not really supported anymore, but it says that embryology copies phylogeny in the way that we have more evolutionary steps of the other mammals, in the way that we have more infolding process of the brain, as a way of we having more surface of the brain. And now, with the intention to describe and note all the anatomical landmarks of the surface of the brain, we begin to have the first description of the more consistent aspects of the brain. Everybody's brain is a little bit different between ourselves, but if we compare all the brains, there is a blueprint, there is a roadmap, and there are some landmarks that will be present in all human brains. So the first very consistent anatomic landmark is the Sylvian fissure, now called the lateral surface of the brain, the lateral fissure of the brain. It has its name given by Dr. Silves de Laboe, and that's why it's called the Sylvian fissure. Then Luigi Rolando described the central sulcus. The central sulcus is a very different sulcus from the rest of the surface of the brain. I like to say that it has 3 special features that we have to look for. First of all, it's one oblique sulcus, so it's not really vertical. It's a little bit placed posteriorly, so it's oblique. It's also a very continuous sulcus. So this is a concept. A sulcus can be interrupted, but not usually the central sulcus. The central sulcus usually it is continuous, non-interrupted. And also it's a lonely sulcus in the way that it usually does not receives other sulci from posteriorly or anteriorly. So it's a very lonely sulci. It's a very distinct and isolated sulcus that we're going to see in the next slides. And then in the end of the 18th century, John Christian Ryle described the island of Ryle, that it is not opposed to any other bone of the skull. It is actually hidden inside the Sylvian fissure, and he first gave his name, but now it's just called the insula, and that's why it's an island of cerebral cortex inside the Sylvian fissure, as we're going to be seeing later. And then in the middle of the 19th century, perhaps Louis-Pierre Graciollet was the first anatomist to understand the brain as a whole, and he really could name and detail all the sulci and the gyri. And he noticed, of course, that the brain does not have natural divisions. It's really a continuum of its surface, of the gyri continuum between themselves without a narrow demarcation, natural division between themselves. But he wanted to separate the brain into lobes. So he borrowed the names of the bones that are overlying the brain, and he just said what is underneath the frontal bone will be the frontal lobe, what is underneath the parietal lobe will be the parietal bone will be the lobe, and temporal, occipital, in the way that we will have four cerebral lobes on its surface. But then the lobes are connected together by the pli de passage or connection arms. They're really the continuation of the gyri together. And we have to understand that at this point was just one anatomical feature. He was not thinking about the functional aspect of the brain. He was just seeing that the gyri continued themselves without a natural demarcation. So in the beginning, we as the anatomists, we were using the bones as the separation of the bones, the sutures, as the separation of the cerebral lobes, because we were not understanding really the lobes itself, really the brain itself. So here it is what an old anatomist would say what was the frontal lobe, for example, was really there was underneath the frontal bone, and the posterior aspect would be the coronal suture. Throughout the years, we begin to understand the surface of the brain, and we changed the coronal suture, for example, the central sulcus. So in a way, the frontal lobe gained 2 or 3 more centimeters more posteriorly in this terminology point of view, because now we are dealing with the central, with the superficial cerebral landmarks. Of course, doing surgery, all these vessels and the arachnoid is overlying the brain, so it's very difficult to see where the sulci and the gyri are. So that's why the anatomist has to work with the brain devascularized, so he can see which sulci are the main sulci, are the most deep ones, and the other ones are more shallow, so he can understand more nicely the brain. The brain will have to be devascularized. The first anatomical feature that we will look in the lateral surface of the brain is the lateral fissure of the brain, also called the Sylvian fissure. This is the lateral extension of the Sylvian fissure, but there is also a ventral extension of the Sylvian fissure that's going to go to the basal cisterns. The Sylvian fissure is dividing the frontal and the parietal lobe superiorly from the temporal lobe inferiorly. The second anatomical aspect that feature that we're going to look for is the central sulcus. As I said, it's an oblique sulcus. It's not really a vertical sulcus, but it's almost vertical. It's called oblique. It's also very continuous in the way that it does not have interruptions through its extension. And it's also a very lonely sulcus in the way, the isolated sulcus in the way that does not receive sulci from anteriorly or posteriorly. And the other line we are going to draw from the preoccipital notch to the parietal occipital feature. So the preoccipital notch is just a notch, a bump that we can see in all brains if we follow the inferior margin of the brain. If we follow the inferior margin of the brain, there is a bump. This is called the preoccipital notch, what is a very good name because it's preoccipital. It's meant to be anterior to the occipital lobe, so that's why it's preoccipital. And then at the medial surface, another speaker will talk in the next lecture. At the medial surface, it's very easy to see the parietal occipital fissure. What is also a good name because it's parietal occipital, so anterior is parietal, posterior is occipital, and it's a very deep cleft, a very deep fissure in the medial surface of the brain. Between these 2 points, we are going to draw an imaginary line. And then we are going to use this line as the anterior limit of the occipital lobe. Most people will just pick up the midpoint of this line and connect to the end of the Sylvian fissure. Other people will just draw the continuation of the Sylvian fissure until it reaches this line. It doesn't really matter, but this is how we are gonna divide this part here, having the parietal lobe superiorly, the temporal lobe inferiorly, and the occipital lobe posteriorly. With this, we'll have the four lobes at the lateral surface of the brain, and because here the operculum is a little bit retracted, we can also see the fifth lobe of the brain, that's the insula, inside the Sylvian cistern here. So we have the four cerebral lobes on its surface, on the lateral surface, and the insular surface can also be called the lateral surface because the lateral aspect of the brain, but it's hidden inside the Sylvian fissure. But what happens to the next lobe, the sixth lobe of the brain? So Paul Broca is a very famous anatomist, most known by the spoken word area that he described in the inferior frontal gyrus, but is also known by detailing and suggesting the existence of a limbic lobe. So he suggested these C-shaped structures around the thalamus in the 19th century, and just 100 years later, they were seen as a distinct lobe. But what he noticed is that some structures are making Cs around the central region of the brain, that is the thalamus, and he called this the limbic lobe. I just want to make it complete that we have 6 lobes and not just 5, and this is the 6 lobes. All this anatomy regarding the surface of the brain has been resumed and explored by many authors. But what it is important for the neurosurgeon, the modern neurosurgeon, is because microneurosurgery is done by the natural spaces of the brain. Professor Ghazi Yassargil was perhaps the first neurosurgeon to use the microscope, the binocular microscope with the 3D and ergonomy that we use today. And he was very clever to detail all the routes that the neurosurgeon can use microsurgically to reach deep inside the brain. And a lot of the intracranial space can be reached just by opening the sulci and the fissures without really going through the brain. So that's one of the main aspects of the microneurosurgery, in the way that we can get inside the fissures and the sulci. We can open them by enlarging with microsurgical techniques, drain CSF, and treat a lot of intracranial lesions that are not really intracerebral lesions, like vascular lesions, like metastases, like meningiomas, for example. A lot can be done without really going through the brain. In this way, we made a contribution by studying the relationship of some sulci key points, where two main sulcus meet together. That is usually an enlargement of the CSF space, of we call the cisternal appearance of these meeting points. And we can use these meeting points as a first point to understand where we are dealing and where we are going to. So we related the set of sulcal key points to the cranial surface and also to the deep inside of the brain. So we can use these key points as the first steps to understand how we can get inside the brain, how we can deal with a lesion. And this you can see at the neurosurgery journal, okay? And with all these points together, we can use this as a framework for us to put the craniotomy first, but also to get inside the brain and to treat our patients more precisely. The surface of the brain itself is formed in a very uniform way. It has gray matter on its surface and white matter on its inside. And all the lateral aspect of the brain, it's made like this, a very uniform way. The frontal, parietal, and all lobes are made like this, but not really inside the brain. Inside the brain, we have a central core that is made by collections of gray matter that appear to be encapsulated by white matter. These are the basal ganglia and the thalamus that appear to be encapsulated by white matter capsules. But the white matter capsules, they do not they are not just inside the central core, they connect this region to the other cerebral lobes. And it's in fact the center of each cerebral hemisphere. So we have two cerebral hemispheres, and in the middle of each cerebral hemisphere, we have a central core. And orbiting the central core, we have the other cerebral lobes. So we can see each cerebral hemisphere as having a central core in its inside and the lobes orbiting it. Another way of understanding the cerebral surface is not by dividing these into lobes, but just as surfaces. We have three brain surfaces. Today we're going to talk about the lateral surface, but of course we have a medial surface and we have one inferior surface. So the brain has three surfaces. Each surface has the main anatomical landmark that we're going to see in the lateral surface is the Sylvian fissure. And as I said, this is just the lateral extension of the Sylvian fissure, but we need to understand also the ventral extension of the Sylvian cistern. The ventral extension continues to the basal cisterns of the brain. We're going to have lectures about this, but this is the cleft. This is all the Sylvian fissure, and at this cleft, we're going to have the MCA, the middle cerebral artery, going through. And all the ventral and the lateral extension of the Sylvian fissure both are separating frontal and parietal lobe superiorly from the temporal lobe inferiorly. This book, for example, has almost 100 years old, and it deals with the lack of consistency of our brains. If we put all the brains together, we are going to see that there is a roadmap, there is a blueprint, there is some landmarks that are very consistent, but other ones change between ourselves. So if we, for example, divide the inferior frontal gyrus into its three parts, the most anterior one called the pars orbitalis because it's overlying the orbit. The intermediate one is the pars triangularis because it's more retracted and it has this shape that resembles a triangle. And then the connection between the inferior frontal gyrus to the precentral gyrus that forms this U, and it's already over the insula, so it's named the pars opercularis. So these three parts, it's the way that we put in the books, right? Because most people will have a shape like this that resemble these three parts. But for example, this subject in the middle, where would the pars triangularis would be? Perhaps here, and in this other subject here, where is the pars triangularis? Perhaps here, very small and really far away from the Sylvian fissure. So as we can see, the shape changes between ourselves, but of course, the lack of consistency usually does not lead to changes in the cognitive power of this brain. The brain can function normally with people that do not follow exactly this roadmap. Okay, so I'm going to try to summarize how the lateral surface of the brain is done by some sentence here. So as we said that we have three surfaces, we also have three poles. Each cerebral hemisphere has a frontal pole, a temporal pole, and the occipital lobe. So three poles. And the poles are very important for especially for TBI, because since they are against the cranial vault, it's very easily to suffer contusions in traumatic in traumas, for example, the frontal, temporal, and occipital lobes. At each lobe, we will have a convergence a convergence of three gyri. So the three frontal gyri will meet at the frontal pole, the three occipital gyri will meet at the occipital pole, and the three temporal gyri will meet at the temporal pole. And the name of these gyri are very easy. So they are superior, middle, and inferior, frontal, temporal, and occipital gyri. So this is very easy. Then we have an ellipse in the middle of the brain formed by the pre-central gyrus and the post-central gyrus. In the middle, we have the central sulcus. And as I said, the central sulcus is continuous and not interrupted. It's not interrupted because the pre and the post-central gyri, they do not connect themselves along the central sulcus. They do connect themselves superior and inferior to the central sulcus, and that's why these both gyri form together this ellipse that some people will like to call this the central lobe. just like the article that Thomas Frigeri wrote with Dr. Rhoton, for example, suggesting that this can be understood as a separate, as a distinct lobe of the brain. And then the functional importance of this region is really distinct as well. The M1, the primary motor area, is located at the precentral gyrus. On the other hand, the somatosensory area is located at the postcentral gyrus. So these two gyri together are of fundamental functional importance for us, and perhaps that's why it's really protected and really in the middle of the brain. Some people will have more difficulty understand the parietal lobe. So the parietal lobe, of course, has the postcentral gyrus and then the two parietal lobules. The lobule is a part of the lobe. We have a superior parietal lobule that is a quadrangular brain shape superior to the intraparietal sulcus. The intraparietal sulcus is a sulcus that is coming from anterior to posterior and dividing the parietal lobe in its two lobules. The superior parietal lobe, of course, superiorly, and the inferior parietal lobule, of course, inferiorly. While the superior parietal lobule is just constituted by one big quadrangular part of brain, the inferior parietal lobule is made by two arched gyri. The anterior one is called the supramarginal gyrus, and it's really going over the posterior margin of the Sylvian fissure, and I believe that's why it's called the supramarginal, because it's going superior to the posterior margin of the Sylvian fissure. Posterior, we have the angular gyrus, is also a horseshoe shaped or the upside down U pointing inferiorly, and between both of them, we have the intermediate sulcus of Jensen. The fifth lobe of the brain is the insula, located deep inside the Sylvian fissure. We're going to talk about this later. And the other surfaces, the medial and the basal surface, we have other people speaking on other days. Now, let's talk about each part. So at the frontal lobe, we're going to look for three gyri merging anteriorly in the frontal pole, and posteriorly, they will be connected to the precentral gyrus. By these connections of the frontal gyrus, the frontal gyri to the precentral gyrus, will make the precentral sulcus interrupted. So while the central sulcus is not interrupted, the precentral sulcus is interrupted. It is interrupted because of these connections of the frontal gyri to the precentral gyrus. So if we follow here the precentral sulcus, it will be interrupted. You see here, here's the connection of the middle frontal gyrus to the precentral gyrus. Superior will have a connection as well, and inferior will have also a connection. This inferior connection is itself the pars opercularis. The pars opercularis is the connection of the inferior frontal gyrus to the precentral gyrus. Professor Ribas, senior, for example, likes to call this the beautiful U, because it's almost always resemble a U-shaped convolution here. This is the pars opercularis itself. It's a U because it's receiving inside the precentral sulcus, and this is a shape that we can look primary in a lot of brains, so we begin to understand the brain by this anatomical landmark here. This is another specimen here, as we can see the same configuration. So here is the interhemispheric fissure. So from here superiorly, the other hemisphere. From here inferiorly is the hemisphere on our side. So here's the superior frontal gyrus. We can see the connection of the superior frontal gyrus to the precentral gyrus, interrupting the precentral sulcus. We can also see the connection of the middle frontal gyrus to the precentral gyrus. This is the connection, interrupting the precentral sulcus, as I said. And the last connection, the inferior connection, the pars opercularis itself, the connection of the inferior frontal gyrus to the precentral gyrus, interrupting also the precentral sulcus. Posteriorly, we have the isolated central sulcus here, continuous, isolated, and oblique, just posterior to the precentral gyrus itself. Another specimen and the same configuration, superior frontal gyrus connecting itself to the precentral gyrus, middle frontal gyrus connecting itself to the precentral gyrus, and the inferior frontal gyrus connecting itself to the precentral gyrus, and posteriorly the isolated, oblique, and continuous central sulcus with these three features that I like to point out here. Okay. Of course, if we see the brain from a superior point of view, we can see that the central area, the pre and post-central gyri, they are more posteriorly located at the superior aspect of them than the inferior aspect of them. This is why they are oblique. So the frontal lobe it's bigger superiorly than inferiorly, and the pre and post-central gyri, they are oblique, pointing posteriorly. As we go superiorly, they will go more posteriorly. Okay, they have this shape here. The frontal base will be summarized in the next lectures. Parietal lobe, as we said, the post-central gyrus, and the post-central sulcus posteriorly. And as the pre-central sulcus is interrupted, the post-central sulcus is also interrupted. Interrupted because the parietal gyri will also connect together with the post-central gyrus. Because of this connection of the parietal gyri to the post-central gyrus, the post-central sulcus will be interrupted. So here is the connection of the superior parietal lobule to the post-central sulcus, post-central gyrus. Here is the connection of the supramarginal gyrus to the post-central gyrus. And these connections make the post-central sulcus be interrupted, differently from the central sulcus that is continuous. So the post-central sulcus is always interrupted. Likewise, the pre-central sulcus. I like to point this because it's a very it's in all brains will have these configurations. Then inside the parietal lobe, we're going to look for this anterior to posterior sulcus here. That is called the intraparietal sulcus. It's a very good name because it's named intraparietal, means inside the parietal lobe, intraparietal. Superior to the intraparietal sulcus, we'll have the superior parietal lobule, this quadrangular shape here. And inferior, we have the inferior parietal lobule. The inferior parietal lobule is made by the first one, the arched superior to the inferior margin of the Sylvian fissure. It's called the supramarginal gyrus. And then posterior, we have the angular gyrus. Between themselves, we have the intermediate sulcus of Jensen. At the next specimen, we have the same configuration. So overlying the posterior margin of the Sylvian fissure, we'll have the supramarginal gyrus. And then posterior to this gyrus, we're going to look for this arched convolution that's called the angular gyrus. But as I said, usually it's an U-shaped pointed inferiorly. And this specimen here, we have this U-shaped pointing superiorly. But we can say this is the region of the angular gyrus. If we cannot really find this shape, we can just say this is the region of the angular gyrus. It's not really consistent among a lot of brains, but here it's a U-shaped convolution pointing superior. Occipital lobe, we will also look for three gyri merging into the occipital lobe. And we can see the same specimen from this posterior point of view. The inferior occipital gyrus is itself the continuation of the inferior temporal gyrus. It's the same piece of brain that continues from the temporal to the occipital region. But at the temporal region, it's called the inferior temporal gyrus. At the occipital region, it's called the inferior occipital gyrus. It's the same piece of brain, but it changed its name as it goes anterior or posterior to the preoccipital notch. So posterior to the preoccipital notch, it's named occipital, inferior occipital gyrus. Likewise, the superior occipital gyrus, it's also a continuation of another piece of brain that's called the superior parietal lobule. So the superior parietal lobule continues itself with the superior occipital gyrus. It's the same piece of brain, but anterior to the parietal occipital fissure, it's named parietal, so it's superior parietal lobule. Posterior to the parietal occipital fissure, now it's occipital, so it has to be named occipital. It's superior occipital gyrus. Between both of them, we are going to look for the middle occipital gyrus. And this specimen here, we have a very horizontal middle occipital gyrus, but we are going to see in the next specimen that the middle occipital gyrus can be in other directions. In the next specimen, we're going to see that the middle occipital gyrus in the other specimen will be more vertical. So as we can see here, the middle occipital gyrus more vertical, Likewise, the superior occipital gyrus is also vertical, and the inferior occipital gyrus more horizontal, but three of them merging together at the occipital pole. The temporal lobe perhaps is the most easy one to understand. So three gyri merging together at the pole, at the temporal pole. Between these three gyri, we're going to look for their sulci, two sulci. The superior temporal sulcus, it's always very continuous and very deep. On the other hand, the inferior temporal sulcus is always interrupted and more shallow. But if we make an effort to look here, to try to find out here an interrupted sulcus, we can see that it's a line forming here. This is the inferior temporal sulcus. In another specimen, we can see the same configuration. So the superior temporal sulcus, very deep and very easily seen. On the other hand, the inferior temporal sulcus, more shallow, more interrupted. But both sulci are demarcating three gyri, three temporal gyri that will merge together at the temporal pole more anteriorly. Just to note that the inferior temporal gyrus is seen at the lateral and the basal surface of the brain because it's making this round appearance. The insular lobe is also at the lateral aspect of the brain, as we can see the insular lobe as we retract the operculum. The operculum is the frontal part, the parietal part, and the temporal part of these lobes that are overlying the Sylvian fissure. They're overlying the insular cortex. And to see the insular surface, they have to be retracted. So this is the retraction of the operculum, okay? The insular surface is separated from the rest of the brain by a circular sulcus of the insula, also called the peri-insular sulcus. It can also be subdivided into the insular limiting sulci. There is one anterior, one superior, and one inferior limiting sulci of the insula. The insula itself is separated in two compartments. The anterior compartment made by short insular gyri that will meet together at an apex, and a posterior compartment made by long insular gyri that will not meet the apex. And between these two compartments, we have the central sulcus of the insula. This is a very nice paper article about the anatomy of the insular region, written by Dr. Ture, Dr. Yashergil, Diane Yashergil, and Professor Osama Al-Mefti. So a very good group of people describing this very nice place of the brain, and they have very spectacular pictures. So if you want to look to this region, go to this article. This is an insula that will have two apexes. So we can see some short insular gyri forming one apex here and another apex forming here. But so some insulas can have more than one apex, but usually they will have just one big and very easily seen apex here. So here we have the short insular gyri forming one big apex here, and the long insular gyri that will not meet the apex. Between them, we have the central sulcus of the insula. Anterior to the lateral surface of the insula, we have the anterior aspect of the insula. It's made inferiorly by the transverse gyrus and superiorly by the accessory gyrus, here going to the frontal lobe, okay? I just want to finish my talk showing some pictures of my fellowship with Professor Rhoton 11 years ago. So everybody know he was really a gentleman, a very nice person to be with, and of course a great professor. And he's here dealing with my specimen and going through my images with his grandson. We had the opportunity to have them both at that time. So his grandson was still very young at that time. I believe he's now going to med school. I don't know if he's finishing med school already. And he was always a good man, very happy. And we have some pizza nights. So I know some people from all over the world are seeing here. These were my graduation day here with friends that I made for all my life. Thomas Frigeri, also a Brazilian, he's watching us here today. Dr. Khan is from Istanbul, people from Japan, and me having my graduation here. And I just want to finish my talk saying thank you, Professor Rhoton. This is Professor Rhoton and his wife 11 years ago. So thank you for all this knowledge and the opportunity to be here with you. This is my email if someone wants to get in contact with me. Okay, thank you, and I'm open to questions now.
Great, Eduardo. Thank you so much for going over the entire lateral surface. And we are open for questions. If you want to write your questions at the chat, we can read that for you. Otherwise, you can just put your hand and open your mic and make a direct question to Eduardo. We do have one question right now. I think Dr. Coriesa is asking, can you explain regarding the anatomy of frontal and temporal operculum?
Okay, yeah. So I'm gonna go through a slide here. So operculum means curtain, what is overlying the insular cortex. So the operculum is not another part of the brain. It's part of the frontal lobe, it's part of the parietal lobe, and it's part of the temporal lobe that are superior to the insular surface. And of course, we have a superior operculum and one inferior operculum. The superior operculum, you said the frontal operculum, but it's more complete saying the frontal parietal operculum, because it's made anteriorly by the frontal and posteriorly by the parietal also. So it's the frontal parietal operculum or the supraoperculum operculum. If you want to go through this article that I wrote together with my father, Dr. Guilherme Ribas here, and you can see the operculum, it has a very particular shape, a sequence of shapes. The first shape here is the triangular, the pars triangularis. It's more retracted from the sylvian fissure. It's pointing to the anterior sylvian point. Is where most people will begin to split the sylvian fissure. It's where the sylvian fissure is usually more cisternal. It's already a little bit more open. This is the anterior sylvian point. Then we have the connection of the inferior frontal gyrus to the precentral gyrus. This is the pars opercularis, as I said, the beautiful U. Then we have another U-shaped convolution. That's the connection between the pre and post-central gyrus. It's also called the subcentral gyrus. Some people will call the subcentral gyrus, or the inferior connection of Broca. It's also a connection here. And then we have the last U-shaped connection connecting the post-central gyrus to the supramarginal gyrus. And closing the sylvian fissure, it is the supramarginal gyrus. The temporal operculum itself does not have a lot of subdivisions. Of course, if we open the temporal operculum, we can note that there are some transverse gyri that are continuum from the superior temporal gyrus pointing to the posterior aspect of the insula. It's usually 2 or 3 transverse temporal gyrus. The most known one is the more anterior one that usually that harbors the primary auditory area. It's called the Heschel gyrus. So this is what we call the temporal plane, and anterior the planum temporale, for example, and anteriorly we have the polar plane, is the planum temporale of the temporal operculum here. So I know it's a lot of information. We might have just one lecture about the sylvian fissure, because it's a very important anatomy for all of us, right? So I think if you just follow us, I think it's gonna be another day with more information about that subject.
Yeah, it gives me a hint to say that it will be next month. We'll be exploring the sylvian fissure and its surgical uses with Dr. Wen next month. So it's a nice introduction.
Yeah.
Any other questions, guys? Come on. I know you do have questions. It's time to ask. It's nice to say to everyone that we have been progressing bit by bit over the brain, right? We have been looking at the basal surface. We did that with Dr. Vincent a few months ago, and then we looked at the medial surface. Now we are exploring the lateral surface, and the idea is truly what Dr. Wen told us at our first meeting, that we are going to be able to see through the skull and see the brain. This is the concept that Dr. Rhoton always emphasized to us, to feed the neuronavigator between our ears and be able to look at the heads of our patients and be able to see where we want to go, the vessels we want to treat, to organize everything in our brain in order for us to make our surgery safer. And yeah, it needs to be said that everything that Eduardo showed us, we can see at the imaging of our patients, so we can relate to the craniometric points as he has been pointing out. Especially the lateral surface is completely related to the craniometric points. Yeah. So we can organize this knowledge within ourselves to be able to guide through the surface we are working at. We do have, yes, come on in, Thomas.
Frigeri? Yeah. You're mute, Thomas.
Please unmute and come on in.
Okay, can you hear me now?
Yes.
Okay, good. So, Eduardo, congratulations about your lab. It was very nice as usual, and I think to know the exact anatomy of the lateral surface of the brain is very important, especially when operating gliomas, which would be the obvious conclusion. But we use here a lot this anatomy to operate cortical dysplasia. And cortical dysplasia, it's even more important to know the anatomy because it doesn't distort the anatomy. When you have a glioma, maybe sometimes the gyros are displaced, but when you have a cortical dysplasia, they are not. The true knowledge of this lateral surface is like essential for our daily practices here in Porto Alegre. Eduardo knows that we have a big epilepsy surgery program, and we do perform surgeries for cortical dysplasia almost every week. And we do an MRI, and we put on a program called the VMTK, where you get a 3D dimension of the cortical surface. And based on the anatomy, we do operate those cortical dysplasias. So it's essential to know this anatomy. So thank you very much, Eduardo, for your presentation. And I'm very happy to be here with all of you guys. When you put those pictures in the end of your presentation, it makes me feel a little bit nostalgic, you know. And it's very nice that we can keep up our contact with Carolina, Wen, and you. And I hope to see all you guys there in Taiwan and have a good time and discuss a lot of surgery and anatomy as well. Thank you.
Thank you, Thomas. You get nostalgic. We get truly old, right? I feel myself very old among you.
So fast, so fast.
But I'm completely okay with that.
Yeah.
Let's see if we have any other questions. If anyone wants to unmute, come on in.
So, Dr. Elizabeth, she said she wants to know about, I don't know if it's just for me. So, excellent class, doctor. I'm working in white matter fiber laboratory for an anatomical study about the terminal segment of the Sylvian fissure. She wants to send me an email. You're gonna, of course, you can send me an email, but before sending an email, wait next month for the lecture about the Sylvian fissure. The terminal end of the Sylvian fissure, it usually has a branching, also a superior and inferior posterior branch of the Sylvian fissure, the more posterior extension of the Sylvian fissure. I'm sure Dr. Wen is going to talk about this. He has a brilliant, very nice lecture about this. Is it Dr. Wen next month? Yeah, okay. Yeah.
Yes.
It is. When do you want to give a small introduction for next month? On the 27th, right? Because 6, next Friday, we do have anatomy, but peripheral nerves. And then the other week, we have skull base. And then on the 27th, it's when with the Sylvian fissure.
Okay. For the next month, the emphasis will be, the focus will be on the clinical application of the silver and fissure anatomy, on how to interpret the angiogram, how to interpret the MRI, and then how to apply it in surgery. So we will combine next month anatomy, imaging, and surgery. So I'm looking forward to meeting you guys again. And I congratulate Eduardo for this wonderful job, wonderful talk. And it's been very nice meeting all of you one more time. Thanks.
I don't see any other questions. I don't see any hands out. I would like to thank Eduardo for a great talk. I think you organize it very well. It becomes easy to follow from this point on. And I want to thank all present and invite everyone for the next Friday and also the last Friday. And also thank Imad for organizing the link, making the advertisement. It's always nice to have you with us, Imad. Thank you so much. If we don't have any other questions or anyone wants to make any comment, Eduardo, thank you so very much.
Yeah. Thank you, Dr. Carolina, Dr. Wayne. It's a pleasure to be here and to continue this journey, just like Dr. Rhoton. Of course, we are here for him, and to divide, right, to share this knowledge with everybody. Anatomy can teach us how to make better surgeries in order to treat our patients better, and we are here to share what we know, and of course we are open to discussions and everything. So we are always learning. So it's very a great opportunity to be here with friends, and if everybody wants to write for us and ask questions, we are open for everybody else.
Yes, this is the mission of the International Rhoton Society, right? To make microsurgical anatomy known and available for our microneurosurgery. Goodbye to everyone, and we see each other next Friday and the last Friday especially.
Okay.
Thank you, guys.
Thank
Very
you.
good to see
Thank
you
you.
all.
Bye-bye.